Yeah, hi, I am Dr. Harish Lamba, a diabetologist practicing in Bajpur, Udham Singh Nagar, and I've been practicing diabetes since last 32 years. And today I'm here to share my experiences with you about the fixed dose combination of Empalina. And I would start with this: is that how early would you add an FDC after metformin in your clinical practice? Considering many type 2 DM patients have a very high baseline HbA1c at the time of presentation. Now, here I would like to say that the evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of micro as well as macrovascular complications in type 2 diabetes, as it was proven by UKPDS, which has been the largest study till date. And it said that patients are most likely to have reduced cardiovascular death risk, CVD risk, with intensive glycemic control. They were those with a shorter type 2 diabetes duration who had not yet developed atherosclerosis. UKPDS also demonstrated a legacy effect, that the legacy effect or metabolic memory. It is that early intensive therapy, because of the difference in the CV event rate of even a 10 years post trial, it was apparent even though no difference in HbA1c levels was seen between the intensive and conventional therapy. Early use of combination therapy in patients with newly diagnosed type 2 diabetes had shown to reduce the progression of atherosclerosis compared with conventional therapy. Even the real world evidence has also proven a legacy effect of early intensive glycemic control in type 2 diabetes. Now, for patients, they say that how does the evidence with Empower Lina combination help us choose these agents for optimal glycemic control and CV risk reduction as well in patients with type 2 diabetes? For patients with HbA1c of more than 1.5%, as guided by the guidelines from ADA and EASC, it is they say that if the HbA1c is more than 1.5% above the goal at the time of diagnosis, ADA and EASC guidelines recommend the first line treatment with a dual combination and an SGLT2 inhibitor as the first post-metformin treatment in patients who have an established CVD, CHF, or CKD. For patients requiring additional treatment for controlling glycemia, similar considerations should guide the addition of a third agent, which may include DPP4 inhibitor if the patient is already not on a GLP-1 receptor agonist, or excluding saxagliptin in the setting of heart failure. The use of an SGLT2 inhibitor, GLP-1 receptor agonist, or DPP4 inhibitor. It may also be added alone or in combination in patients without atherosclerotic cardiovascular disease, heart failure, or CKD, if there is a need to minimize hypoglycemia. And next question usually asked is, what are your thoughts about an early intervention with the fixed dose combination of Empalina as an add-on to metformin? Here I would like to mention one fact that as per EMPA-REG and Empalina studies, which had a very bigger scope and which had covered most of the patients, which was a very big trial till date and a robust study, they had shown the best effects of the fixed dose combination, and especially about the uses of EMPA in kidney disease. The combination with complementary mechanisms and pleiotropic benefits, it may be suitable option across a range of patients, including those with established atherosclerotic cardiovascular disease or high risk, established heart failure or CKD, due to the tolerability of the combination, in addition to the potential benefits of empagliflozin in CV and renal outcomes, and no increased risk of heart failure with either agent. Now, again, I would like to state that compared to the other studies like DAPA kidney or Cormelina or other studies, REDEN study, the Empalina has been a wonderful and all encompassing study. And according to this, the early achievement of HbA1c goal, that is less than 7% with Empalina, could reach target easily. And following advice still can be given to patients while initiating this combination: maintaining hydration, perineal hygiene, adequate monitoring of body weight and blood pressure, blood glucose on routine basis, informing the treating physician in case of symptoms of low blood glucose. Then they say follow the sick day rule. The sick day rule is that in case feeling sick due to fever, infection, poor appetite, nausea, vomiting, or diarrhea, further evaluation is needed to be done in case of burning or pain during micturition. Now, according to recent ADA 2022 standard of care, first-line therapy depends on comorbidities. This is a factor to be considered, that comorbidities are very important to be concerned, when they ask about that, what are the considerations in terms of patient factors you will think about while initiating this therapy to the patients. The comorbidities, patient-centered treatment factors, and management needs, and generally includes metformin and comprehensive lifestyle modification. That is a first-line treatment. Now, the treatment goal involves a control of glycemia and CV risk factor management and a patient-centered approach to care. The choice of pharmacologic agent now considerably considers the comorbidities in addition to the risk of hypoglycemia. As per the guidelines by ADA and EASD, they mentioned the last was that compelling needs to take care of hypoglycemia, impact on weight, cost. But now this is the choice of pharmacologic agent now considers the comorbidities, which is very important to be considered along with the potential side effects and patient preferences. Early glycemic control leads to better outcomes, including a reduction in long-term macro and microvascular complications. For patients with inadequate glycemic control on metformin, addition of the single pill might be considered to help establish optimum glycemic control while reducing pill burden, which is a much talked about topic these days, the pill burden. So that leads to the adherence to the treatment by the patient and avoiding clinical inertia also in intensifying therapy, which is again a very important factor to be considered because doctors usually have inertia initially to intensify the treatment. When metformin is not suitable and empagliflozin or linagliptin is being considered as an alternative first-line treatment, initial combination therapy may be considered to achieve targets more quickly, particularly in patients with 1.5% HbA1c higher than the target level. It is reported that DPP-4 inhibitors, they improve beta cell mass and function via beta cell differentiation and proliferation, accompanied by a decrease of oxidative stress and inflammatory cytokines. So the DPP-4 inhibitors have a very unique point here. It is also reported that SGLT2 inhibitors, they also improve beta cell mass and function via similar mechanisms as DPP-4 inhibitors. Although the mechanism of glucose lowering effect is totally different with both the molecules. In experimental study, combination of DPP-4 inhibitor and SGLT2 inhibitor, it exerts more beneficial effect on beta cell mass and function, especially in an early phase of diabetes rather than in an advanced phase. So here again, I would stress on the point of getting over the intensive treatment inertia and start the treatment right at the very beginning. EMPA or LIDA is available as first-in-class treatment in SGLT2 inhibitor and DPP-4 inhibitor combination group of drugs. At week 24, EMPA-LINA, 25 milligram of EMPA and 5 milligram of LINA, it showed statistically significant HbA1c reduction of 1.08 and add on to metformin when the HbA1c was lower, that is 7.99. But when HbA1c was more than 8.5 or equal to 8.5, the decrements by EMPA-LINA 25/5 has demonstrated 1.81. See, it was there 1.08 and here it is 1.81. A considerable significant improvement in the HbA1c reduction when the HbA1c baseline was higher. As we know that the higher the baseline HbA1c, the better the reduction and the earlier the reduction. The change in FPG reduction with EMPA-LINA was 32.2 at baseline FPG of 156 at week 24. So again, a significant achievement, 32.2 in just 24 weeks and maintained at week 52 in metformin treated groups. Higher percentage of patients achieving HbA1c less than 7% were reported for both single pill combinations versus EMPA 10 milligram. Now, early achievement of goal, only FDC arm of EMPA-LINA could reach target HbA1c at 12 weeks compared to monotherapies. This combination offers a suitable component in strategy to achieve target HbA1c without hypoglycemia and weight gain, the two most important factors that we always consider to avoid hypoglycemia and weight gain. Additionally, it will reduce the daily pill burden in the population, potentially improving adherence to and optimizing the benefits of treatment of diabetes mellitus. Even with the changes in the circulation and changes in the cardiac preload and afterload caused by empagliflozin, that improves the cardiac working and thus the heart failure status and even increases the hematocrit by reduction in the volume and natriuresis, and even it does uricosuriya also. So all in all, this combination is a perfect combination, an ideal combination, and I would strongly recommend that it should be started as early as possible in both the cases, patients without any comorbidities and the patients with comorbidities after first-line treatment with the metformin and lifestyle management is not sufficient. Thank you very much.